Imagine walking into a doctor's office, right? And you have this medical issue that is completely, like, utterly destroying your intimate life.
Right.
Now, if you are a man with diabetes, your doctor actually follows a really strict clinical guideline to screen you for this exact problem. And they will, like, almost immediately offer you a pill to fix it.
Yep, it's standard procedure.
But if you are one of the 71% of women with type 2 diabetes experiencing literally the exact same biological breakdown, you get complete, absolute silence.
Yeah, I mean, it's honestly one of the most glaring disparities in modern metabolic care.
It's crazy.
It really is. That 71% statistic, that represents a staggering number of women suffering from severe physical dysfunction, and they're doing it almost entirely in the dark.
Welcome to the deep dive, everyone. Today we are pulling from a massive stack of sources. We've got clinical guidelines from the NIDDK, the Mayo Clinic, Diabetes UK, and even some training courses for healthcare providers.
Lots of heavy medical data to sort through today.
Exactly. And our mission is to take all of this clinical data and demystify exactly how blood sugar impacts your nervous system and your intimate health. We are going to figure out why this is so heavily under-discussed in the medical community.
Which is a huge problem.
A massive problem. And most importantly, we are going to uncover the actionable solutions you can use to advocate for yourself. Because if you or your partner are dealing with this, you need to know it is a physical reality. It is absolutely not just, in your head.
Right, because to really grasp how that physical sensation is lost, we have to kind of zoom in on how diabetes attacks the body's communication network at a cellular level.
Okay, let's unpack this.
Well, the nervous system relies on a very delicate balance of nutrients. Over time, chronic high blood glucose, along with high levels of circulating fats like triglycerides, creates this highly toxic environment.
Okay, wait, I want to pause right there. Because when I hear diabetic nerve damage, my mind instantly goes to the standard warnings, right? Like you hear about people losing a feeling in their toes or doctors constantly checking their feet during an exam.
Yeah, so that is peripheral neuropathy.
Peripheral, okay.
Right, and it affects the peripheral parts of your body, the extremities, which is why you get that numbness, tingling, or, that shooting pain in your hands and feet. Doctors screen for it constantly because it can lead to visible complications like ulcers.
Which are obviously very serious.
Absolutely.
Yeah.
But there is a second type of nerve damage operating entirely behind the scenes, controlling the organs you don't actively think about.
Oh, you mean the autonomic nervous system?
Yes, autonomic neuropathy. So this system manages your heart rate, your digestion, your bladder, and your sex organs. And the way diabetes damages these nerves is actually twofold.
Twofold? How so?
Well, the high sugar directly harms the nerve fibers themselves, but it also destroys the microscopic blood vessels that feed those nerves. So the nerves literally begin to starve from a lack of oxygen and nutrients.
Oh, wow. Okay, if I could try to visualize this, because usually people say it's like frayed wires, right?
Yeah, that's the common analogy.
But it sounds more like, I don't know, a high-speed fiber optic network running under a city. And high blood sugar is like a rogue construction crew accidentally digging up and damaging those cables one by one.
That is a brilliant way to picture it, actually.
So the signal doesn't just neatly switch off. It gets delayed, it gets misdirected into pain signals, or eventually it just drops entirely.
Exactly. And when that rogue construction crew damages the autonomic network connected to the vagina and the clitoris, it can cause partial or complete loss of sensation.
Just completely numbed out.
Yeah, the physical touch is happening, but those starved nerve endings simply cannot transmit the signals of pressure or stretch back to the brain.
Which obviously means the brain never gets the memo to kickstart the arousal process.
Right. The physical blunting of sensation directly paralyzes the sexual response cycle. I mean, without that sensory feedback, the body has literally no idea it needs to begin the physical changes necessary for comfortable intercourse.
Wow. If you are listening to this and wondering why your body isn't responding the way it used to, I really want you to hear this.
Yeah.
It is a biological mechanism breaking down.
It's physical.
Exactly. It is not a personal failing. It has nothing to do with how much you love your partner. And you aren't just inexplicably losing your drive. Your fiber optic cables are literally being damaged by a metabolic disease.
And those cables are only one piece of the puzzle, unfortunately. Even if a faint signal does manage to make it through the tissue itself has to be capable of responding.
Right, which means we have to look at the plumbing, because arousal requires a massive, rapid change in blood flow, right?
Correct.
So how does a diabetic environment stop the physical tissue from responding?
This comes down to a process called endothelial dysfunction. So the endothelium is the inner lining of your blood vessels.
Yeah.
In a healthy sexual response, your body sends out a chemical messenger called nitric oxide. You can sort of think of nitric oxide as a biological text message that tells your blood vessels to relax and open up wide.
So it triggers the blood flow?
Yes, this allows a rush of blood to flood the genital tissue, causing engorgement and triggering natural vaginal lubrication.
Wait, okay, if the nitric oxide is the text message, what is blocking the message from going through?
Compounds called advanced glycation end products, or AGs.
Advanced glycation end products. Let's break that down.
Sure. Glycation happens when excess sugar molecules in your bloodstream essentially crash into proteins and fats, permanently sticking to them.
Like coating them in sugar?
Pretty much. It turns healthy, flexible tissues into stiff, damaged structures. And the buildup of these AGs creates severe oxidative stress inside the blood vessels.
Which I'm guessing is bad news for that text message.
Very bad news. This stress damages the endothelium, which totally halts the production of nitric oxide. And the result is ischemia.
Ischemia meaning a restriction of blood flow.
Yes. Specifically, a restriction to the dense network of microscopic blood vessels in the vaginal wall.
Yeah.
The blood literally cannot get to where it needs to go to create arousal and lubrication.
Okay, here's where it gets really interesting to me. I'm stuck on this concept of the stiffened blood vessels blocking arousal because based on the clinical sources we reviewed, isn't this the exact same vascular plumbing issue that causes erectile dysfunction in men?
The underlying disease process is identical.
Identical. Really?
Yes, in the womb, female clitoral and vaginal tissue and male penile tissue actually start out as the exact same biological blueprint.
Oh, wow.
Yeah, they developed from the same origins and rely on the exact same nerves and blood vessels to function.
So when diabetes creates this toxic, high-sugar environment that destroys those pathways, men experience erectile dysfunction and women experience severe dryness, lack of engorgement, and a complete loss of sensitivity.
That is the medical reality. It is literally the same systemic breakdown presenting in different anatomy.
Then why is the diagnostic landscape for women so murky? I mean, if a man says he has ED, the doctor immediately knows what it is. For women, it just seems to get written off or confused with a dozen other things.
Well, the difficulty for women is that diabetes rarely causes just one isolated problem. It creates a systemic environment that triggers all these overlapping culprits.
Overlapping how?
For instance, high blood sugar means high sugar content in your urine and your vaginal tissues.
Which is basically an all-you-can-eat buffet for bacteria.
Unfortunately, yes.
Yeah.
It becomes a prime breeding ground. Women with diabetes frequently suffer from recurrent yeast infections, often called thrush, as well as constant urinary tract infections.
Ugh, sounds awful.
It is. These infections cause microscopic tears, itching, burning, and severe pain during sex.
And then add to that the fact that many women dealing with type 2 diabetes might also be entering perimenopause or full menopause.
Which introduces falling estrogen levels. Estrogen is the hormone responsible for maintaining the thickness, elasticity, and natural moisture of the vaginal wall. It is also vital for facilitating that nitric oxide text message we talked about earlier.
So without estrogen, everything just shuts down even more.
Exactly. When estrogen drops, the vaginal tissue thins out and becomes incredibly fragile.
So you have a patient dealing with starved nerve endings, stiff and restricted blood vessels, recurrent yeast infections, and thinning tissues from hormonal drops. I mean, that sounds like a recipe for absolute misery.
The medical term is dyspareunia, which simply means painful sex. But painful barely covers the reality of dealing with all those overlapping physical factors at once.
Yeah, and we have to talk about the emotional fallout of this too. You cannot have a body that is actively fighting you on all these fronts without it taking a massive psychological toll.
Now, the psychological burden is immense, and it stems from something clinicians call diabetes distress.
Let's pause on that. What does diabetes distress actually look like day to day?
It is the mental burnout of managing a relentless 24/7 disease. You are constantly doing mental math calculating carbs, checking blood sugar levels, adjusting insulin, worrying about long-term complications.
Like a full-time job you can't quit.
Precisely. That cognitive load alone is exhausting, and exhaustion kills sexual desire. Furthermore, individuals with diabetes have a significantly higher risk of clinical depression.
And the sources noted that depression increases the risk of sexual dysfunction by 50 to 70%.
It creates a devastating bidirectional loop.
The depression causes dysfunction, and the dysfunction causes depression.
Exactly. Sexual dysfunction deepens the depression, and the depression worsens the sexual dysfunction.
Yeah.
And then, we also have to factor in the impact on body image.
Right, the physical devices required to manage the disease.
Yes, many patients wear continuous glucose monitors permanently attached to their arms or stomachs, or they carry insulin pumps. They might also deal with lipohypertrophy.
Lipohypertrophy, which means what exactly?
Those are the raised, fatty, sometimes bruised lumps that can form under the skin from giving yourself repeated insulin injections in the same area over and over.
I mean, imagine trying to feel relaxed and intimately connected with your partner when you have medical alarms buzzing, devices taped to your body, and skin changes you might feel self-conscious about. It completely pulls you out of the moment.
The combination of the physical nerve damage and the psychological burnout is just overwhelming.
Which brings me to the part of the research that I honestly found the most frustrating. So, what does all of this mean for the patient sitting in the exam room? The data we looked at shows that 72% of women with diabetes actively want to talk to their healthcare provider about these sexual difficulties. And
Yes.
73% want the provider to be the one to initiate the conversation. I mean, they are sitting on the exam table practically begging internally for the doctor to bring it up.
Yet there is no routine screening for women's sexual problems in standard diabetes care. None.
But the guidelines explicitly state that men should be regularly screened for erectile dysfunction. Why is there such a massive gap? If a doctor has the time to ask a male patient about his sex life, why do they suddenly run out of time when a female patient walks in? Is it like a lack of training, or is it just a lingering bias about female sexuality?
To be honest, it is a toxic combination of both.
Really?
Yeah.
Mm.
In a standard 15-minute appointment, providers often triage what they consider to be the most life-threatening issues.
Mhm.
Many doctors admit they lack specific training in female sexual dysfunction, leading to this sort of can of worms fear.
So they're afraid of what they'll find.
Exactly.
Yeah.
The thought process is, if I ask about her sexual health and she says she is in pain, I don't actually know how to treat it, so I'm just going to avoid the topic entirely.
That is wild. They just ignore it.
But you also hit on the unconscious bias, which is very real. Historically, the medical establishment has viewed male sexual function as a mechanical necessity that needs to be fixed. For women, there's this pervasive assumption that a decline in sexual function is just a natural part of aging or, a normal symptom of menopause.
Rather than a direct, treatable complication of a metabolic disease.
Right.
It makes you wonder how many thousands of women are out there suffering in silence, thinking their body is just broken, simply because their doctor assumed it wasn't a priority to fix.
Too many.
Which is exactly why you, listening to this deep dive right now, need to be armed with the facts. If the medical system isn't going to hand you a solution, you need to know exactly what treatments exist.
Well, the good news is that there are highly effective interventions, but they do require the patient to take a very proactive approach. The absolute first-line defense is getting control of your glycemic index.
Getting to the root of the toxic environment.
Right. Stabilizing your blood sugar and keeping your HbA1c levels in your target range is the most critical step. I mean, you cannot wave a magic wand and reverse all the existing nerve damage, but stabilizing your glucose halts the rogue construction crew.
It stops them from digging up more cables.
Exactly. It stops the progression of the neuropathy and allows the body to optimize whatever nerve function remains.
That makes total sense. Now, the sources also dug heavily into lifestyle interventions, and I really want to talk about the Look Ahead study because the numbers were just incredible. I saw the statistic 83% versus 64%, but what was actually happening in that trial?
So Look Ahead stands for Action for Health in Diabetes. It was a major clinical trial focusing on obese women with type 2 diabetes. They split the participants into two groups. One received standard diabetes education, and the other underwent intensive lifestyle interventions.
Like what kind of interventions?
Specifically, adopting a Mediterranean diet and significantly increasing their physical activity. And what they found was that the women in the intensive group were significantly more likely to remain sexually active over the course of the study.
Okay, but what is the biological mechanism behind that? Like, why does eating a Mediterranean diet and walking more suddenly preserve vaginal sensation?
It actually comes down to visceral fat and inflammation. Adipose tissue, or body fat, isn't just inactive weight, It is hormonally active tissue that pumps inflammatory chemicals into your bloodstream.
Oh, I see.
By losing weight and eating a diet high in healthy fats and antioxidants, these women drastically reduce their systemic inflammation. That allowed their blood vessels to heal, which meant the endothelium could start producing nitric oxide again, restoring blood flow to the pelvic region.
That is fascinating. But lifestyle changes take time. For someone dealing with severe pain and dryness today, we need to talk about immediate, direct relief. The guidelines made a huge point about educating patients on the difference between lubricants and moisturizers.
Yes, this is a crucial distinction, and a lot of patients confuse the two. Water-based lubricants are reactive. They are designed to be used immediately prior to and during intercourse to reduce friction. They sit on the surface of the skin and are very temporary.
So it's like putting oil on a squeaky hinge.
Precisely. Vaginal moisturizers, on the other hand, are proactive. They are applied regularly, usually every 2 to 3 days, regardless of whether you are having sex or not.
Oh, so it's more about maintenance.
Exactly. They are actually absorbed deep into the vaginal tissue to improve overall hydration, restore elasticity, and balance the vaginal pH, which helps fight off those recurrent yeast infections we talked about. To manage diabetic dryness effectively, you really need both tools in your cabinet.
Got it. Now, what about waking up the nerves and getting that blood flowing again mechanically?
While medical and physical therapies are highly recommended by the experts, pelvic floor physical therapy is incredible for this.
How does that help with sensation?
When a woman experiences painful sex repeatedly, her pelvic floor muscles instinctively tighten up in anticipation of the pain, right? It creates a vicious cycle of tension. A physical therapist can help release those tight muscles. Vaginal dilators can also gently stretch tissues that have contracted over time.
And the sources also explicitly mentioned vibrators as a medical tool.
They did. Vibrators are FDA-recognized medical devices for a reason.
Right.
They provide concentrated mechanical stimulation that forces blood flow into the clitoral and vaginal nerve endings. It is a highly effective way to manually wake up that starved tissue when the autonomic nervous system is lagging.
Okay, now regarding that starved tissue, we established earlier that female erectile tissue is built from the exact same blueprint as male tissue.
Yes.
Well, for men, the standard medical fix to force blood into that tissue is a PDE5 inhibitor drugs like Viagra or Cialis. So does Viagra work for women with diabetes?
That is actually one of the most hotly debated questions in sexual medicine right now.
Really, why is it debated if the plumbing is the same?
Well, theoretically, because the vascular mechanism is identical, a drug like sildenafil should work perfectly to force blood into the vaginal capillary plexus. However, the clinical trials for women with diabetes have only produced low-quality evidence so far.
That's disappointing.
It is. Some small studies show a slight improvement in arousal and orgasm, but they lack large-scale, definitive confirmation. So as of right now, it is not a standard prescription for women.
But if the diabetes is overlapping with menopause, hormone replacement therapy can be a game changer, right?
Without a doubt. If falling estrogen is compounding the diabetic damage, localized vaginal estrogen therapy like an estrogen cream or a ring is incredibly effective.
And that's pretty safe.
Yes, it doesn't have the same systemic risks as oral hormones, and it directly targets the vaginal wall to restore tissue thickness and elasticity, which dramatically reduces pain.
Okay, let's pull all of this together, because the goal of this deep dive is really to hand the power back to you, the listener. We know that diabetic neuropathy starves your nerve endings, and vascular damage physically blunts sensation by blocking blood flow. We know the psychological burnout of managing diabetes heavily compounds the issue.
It's a lot to deal with.
It is. But we also know that stabilizing your blood sugar, adopting an anti-inflammatory lifestyle, utilizing that 1-2 punch of moisturizers and lubricants, and exploring pelvic floor or hormone therapies can actually reverse this trend.
The mechanisms are understood, and the tools are sitting right there. The science really does support you.
And honestly, the most powerful tool you have right now is your own voice. Bring this up at your next annual review. Do not wait for your doctor to ask, because the statistics show they probably won't. Advocating for your own physical pleasure is literally advocating for your overall metabolic health.
Absolutely. And, on the topic of overall health, I want to leave you with a concept that is just beginning to ripple through the broader medical community, and it is profound.
Okay, lay it on us.
We know that in men, erectile dysfunction is no longer just viewed as a sexual problem. Cardiologists now view it as a vital sentinel marker.
A sentinel marker meaning like an early warning system.
Yes. Because the blood vessels in the penis are so microscopic, they become restricted by systemic vascular disease years before the larger coronary arteries around the heart do. ED is essentially the canary in the coal mine for a future heart attack.
Oh, wow. Okay, I see where you're going with this.
Yeah.
If the vascular network in the female genitalia is built from the exact same biological blueprint, and it is damaged by the exact same metabolic processes.
Exactly. Could tracking a woman's loss of vaginal sensation eventually be utilized by the medical community, not just to improve her sex life, but as a critical, life-saving early diagnostic tool for female cardiovascular disease?
Wow, that completely reframes the entire
It
conversation.
really does.
It stops being just a quality of life issue that doctors sort of brush off and becomes a literal lifesaver. The diagnostic landscape isn't actually murky. The signals are flashing right in front of us, warning us about the health of the entire cardiovascular system.
We just have to be willing to look at the data.
And more importantly, we have to stop being afraid to talk about it.
It is definitely time to bring the conversation out of the shadows.
Thank you so much for joining us on this deep dive. Keep asking the hard questions, keep advocating for your health and your happiness, and we will catch you next time.